Dr. Pramod Bende will speak on membrane peeling in advanced PVR.
At the outset, let me thank organizers and particularly Dr. Malika for giving me opportunity to be part of this instruction course. So basically just a picture showing what you call as pre-retinal membranes or subretinal membranes. You have a spectrum of the membranes you see in a proliferative diabetic, proliferative vitreoretinopathies. So that's basically picture is very variable and each case demands individual attention. There is no one plan works for all the cases. So membrane surgery, again instrument gauge is a surgeon's preference, but the goal is to remove all the membranes to relieve all the traction to make retina mobile enough to reattach. So that is what you would like to achieve is what retina is here and at the end you want something like this. So technique depends on location, extent, vascularity of the membranes. You can use bimanual or unimanual technique basically to mobilize the retina enough to flatten it down. So just quickly we'll go few areas. This is an immature membrane. Sometimes it is extremely difficult to visualize. You have some pigmentation here. You just keep on scratching, massaging, and I mean various instruments can be used, bend needle or MVR or pick, and somewhere you get this edge as you see here. Again, if retina is mobile, things are not that easy. Once you start seeing membrane, the clue here is retina is stiff. Sometimes you see the in between folds or course of the vessel may not be stressed properly. So those are the situations probably force you to think about that probably you are dealing with some membranes. Initially sometimes they are so transparent, difficult to make out. But once you have an edge, now you follow this edge, keep on peeling and then you'll surprise initially where we thought there is no membrane. In fact, entire retina was covered with a membrane. Once you start peeling, it keeps on coming. The pull should always be again from disc towards the periphery so that gives you counter traction here and thus ultimately you get the whole membrane out. If you have a little bit mature membrane, they are easy to see. You can have a focal, here is a posterior pole and this was a diffuse membrane, extensive. This is actually a 20 gauge old video just for a representation. I am just using this. View is very clear and see. Again, either use forceps or spatula once to get edge and in between folds you are going gently trying to teasing it out and pulling spatula and then you get the edge when they start using a forceps to peel this membrane off. Once retina start becoming mobile, if necessary, you can use a PFCL to stabilize the posterior pole so that peripheral dissection can become relatively easier. Well, if you have a mobile retina, there is another problem. You have extensive membranes here, as you see, and posteriorly and in the periphery, and there is no counter traction. So again, as I said earlier, always try to get the edge and try peeling away from the disc towards the periphery. You can use a continuous gentle traction so that will help that holding that tug long enough that slowly membrane peels off from the retina and once this fold is off, then probably easier for you to go towards the periphery. If membranes are extensive, again the retina is mobile, you are dealing with the periphery, bimanual dissection is much better off here. Here I use a light pipe, on the other side you are having a chandelier. So one hand you are holding the membrane with a forceps and other eye what you are seeing is retina being tapped backward. I am not pulling the membrane, holding the membrane and pushing the retina back in fact so that to prevent iatrogenic breaks. And here obviously there is a giant tear, this was like it's not working properly. Giant tear was, there is a retina is missing here and this membrane is again teased off bimanually. So now with MIVS, sometime you are existing your cutter, the port itself can be used as a pick. So you keep on rubbing or massaging and scratching on between the folds and where you have, see, and that helps you to peel off most of the membranes tissue or pigments, mobilize the retina, and it acts as a massager as well. So it takes some time and the advantage is again if the membrane which is floating or pigments are coming out, you can suck it there itself or shave it off so you don't have to keep on changing instruments here. This video is a little bit fast forward just for a time constant and that's what it goes. And this is what is end stage here, whole like a funnel is open. How not to peel, that's another issue. That's what exactly what Dr. Lalit Varma also shows when you hold it and peel it like this, and that's what retina torn there, it started bleeding. So what you need is gentle tug going tangential to retina, and if necessary use a bimanual dissection to tap the retina back rather than pulling whole thing off. Don't want to land up this type of situation. So you again enter PVR, this retina is missing inferiorly. This was a complication of a fishing expedition of the nucleus, and extensive PVR, peripheral membranes, always your bimanual dissection is better off. See again here I am pressing the retina backward, holding the membrane up, so that's way you minimize the risk of creating iatrogenic complications. And this is again subretinal gliosis. You can have, if less membranes, you can make a opening here, localize and pull the membrane out, band out. But if you have extensive membrane, but you ensure that don't cut the retina. Although I was planning here to do a 360 retinotomy later on because the retina was contracted, but if you cut the retina first and be with mobile retina, sometimes difficult those membranes up. So what you do is create a limited opening first, peel the membranes off. This is again napkin ring around that, extensive subretinal proliferation. So I had two openings either side, peel the membranes on, and this is like end of that napkin ring is coming out, which is holding the posterior pole back. And once that is done, you put the PFCL, flatten the retina, and finish your surgery. Just to summarize, in detachment, periretinal membranes are predominantly due to exaggerated healing response, making retina stiff and immobile. Meticulous removal of all these membranes over entire retina is critical to remobilize the retina for successful reattachment and to minimize the recurrence of detachment. Choice of the instrument depends on a surgeon's discretion. Thank you very much for patient hearing. Thank you.
Excellent videos, Dr. Pramod. Do you think, did you have an experience where you thought you've done enough membrane peeling and now you plan to go to fluid air exchange or oil, and then you find that the retina is actually not settling down, and then you not settling at all? Do you think it was the transparent membranes and then you go back again, start fluid and stay in, remove?
It does happen once in a while, particularly when you have immature membranes, and quite some time you removed enough. But what happened with the experience, you know, at the end, before doing fluid air exchange, you try tapping retina all around, assess the mobility. Also try to trace the course of the blood vessels. While tapping retina, sometimes you realize some shining, glistening reflex you see, then you know something is not right there. But yes, suspected cases, you feel reasonably membrane, you try fluid air exchange. Again, is a gradual exchange, start maybe around 20-25 millimeter of mercury, go slowly, aspirate fluid slowly, allow retina to stretch. And when it starts stretching, that is another way of assessing. You see somewhere retina is stretching too much and you know not getting flattened, then you know something is not right. Probably you need to go back. Sometimes that also difficult, and if you do very fast fluid erections, it just gives way and this whole thing will tear off.
Yes,
uncontrolled tear can develop.
Yeah,
Sometimes subretinal membranes can easily miss as well.
So how do you identify those subretinal membranes?
Well, so you go back again, inspect everything, particularly peripheral retina. Now here again you need to differentiate between whether they are membrane or you are dealing with intrinsic contraction of the retina. And quite some time again, we need to assess subretinal space. Probably necessary, maybe limited retinotomy you do, look at subretinal. Your tap again you see sometimes those membranes, sometimes fine network or even thin entire additional membrane which is subretinal covering entire retina, and that membrane sometimes very difficult to make out. So when you do retinotomy and you start seeing that membrane, peel that off. Try PFCL again sometime. That also helps you to stretch the retina and probably localize. If few membranes are there, you will be able to peel those.
Yeah, and what are the risks of having subretinal PFCL when you have a large retinotomy and maybe the retina is not flat, maybe there's still some contraction? So have you had the experience of the PFCL going subretinal and then having to remove it?
It does happen, because now when we do settling the retina, there are two ways. Either we try to do fluid air exchange or use PFCL to flatten the retina. So the way, if traction is not relieved, if you are using air goes subretinal, suddenly retina balloons up. Or once retina start flattening, we are using PFCL, slowly you start flattening, one edge will be going up, other edge start flattening. And if brakes are that side, and where the side where you have brakes, generally because there is a partly relieved traction, retina starts flattening on that side, and one moment comes, all of a sudden entire PF cell runs over, enters to that break, again whole funnel is closed.
Yeah, that's right. So that can be a disaster. Many times if you go very quickly with fluid air exchange, or you can have a lot of subretinal air and the entire retina coming like a balloon. Any questions, Madhu?
So thanks for this excellent video, sir. So in some cases where you have decided not to put a belt buckle, but you proceed with PVR membrane peeling, and then in the end you feel like there is either an intrinsic retinal contraction or some part of the membranes you are not able to peel. So would you prefer going for an RR? What will be your decision? Like when do you say like I'll go for a RR, or I'll support it with a 276 combined after starting a vitrectomy?
Well, it's a personal choice. Again, probably I'm going to talk same talk in a next session. So as a personal choice, almost all RD, particularly with PVR cases, I prefer encerclage almost always. That's my choice personally, and I never repented using that one till now. That is one thing. Second thing is now you have a reasonable peripheral membrane. We are in a dilemma, and choice between relaxing retinotomy and buccal. If there is a possibility, if you extreme periphery, you can't peel membrane properly, or you feel retina is not that mobile, it is somewhere difficult to tell exactly, but mild, moderate tug, contraction, phakic eye, and probably you feel you can get away with buccal. I would not hesitate to add on buccal. Retinotomy is always, for me, is always the last choice. Okay.
Thank you,
so,
sir.
I'll just connect here.
Comment, Dr. Bhende.
Yeah, but retina is too contracted, membranes are very, very posterior, or so that situation, like and carrying is posterior, buccal will not support that area, so you don't have choice but to cut the retina.
Thank you, sir.
And how often do you use the heavy silicone oil for inferior PVR?
Yes, obviously, rather than inferior PVR, I would say if you have multiple breaks at a multiple location, multiple meridian, where gas bubble obviously will not be able to support, and reasonably contracted retina, obviously your choice will be silicone oil. And other factors like age, other comorbidities as well. Inferior retina, whether gas or oil, either way is not going to have a proper support, and particularly, in fact, there's always quite some time, rather it's very common now, because now with optos, if you see erect sitting patient and optos, you take a photograph, almost all the eyes you will have some amount of incomplete field.
Yeah, so I meant heavy silicone oil.
So
Heavy oil.
heavy silicone oil, I have personally not having much use except removal, but again also that does not cause really that much extra added benefit.
Right.